So thank you everybody for joining the next webinar of the Asian Geriatric Oncology Society. I would like to begin by saying that we have very ambitious plans for the year 2025. AGOS has developed a vision document and we have 25 goals for the year 2025. One of them is this webinar. And Dr. Prem Narasimhan, a senior geriatrician and with special interest in geriatric oncology, who's the geriatric oncologist at MOC, is in charge of this webinar program. And international faculty like Dr. Maria are there thanks to uh, Prem's connections and Prem's initiative. For today, we have Dr. Chirantan Bose. He is a molecular oncologist. I should say he's molecular oncologist par excellence. And he's, been all over the world. And right now he's the molecular oncologist with the largest chain of oncology centers across India and now even outside India. So Chirantan, it's a proud privilege to have you with us. And I'm sorry that Prem has had a difficulty, but I think he has joined now. So shall I hand over to Chirantan to please start the proceedings? Or Prem, are
Thank
you?
you. Yeah, we
Prem, are
can.
you?
I think Dr. Prem has joined.
Yeah. Prem, can you hear me? Prem, go ahead. I just introduced you and Chirantan. Please go ahead. Oh, he says still tech failure. So Chirantan, I think I will have to request you.
Yeah, sure.
Go ahead.
Thank you, Dr. Purvish Parikh, sir, for your very kind introduction. Our work in the field of oncology is only guided by senior teachers and mentors like you. And I think as a fraternity, it's our effort to bring the knowledge that we assimilate with modern technologies into the use of patient welfare, benefit, and to enhance lives of cancer patients. Geriatric oncology is a very specialized domain with a high area of need as we are seeing aging population. So I would say India, which was historically at the backdrop of geriatric sciences because we have been a younger population, now we are seeing a very high demand as our aging population is very rapidly increasing because obviously of better lifestyles, better healthcare facilities. And thank you, Dr. Prem, for having me on this forum. Uh, and we are seeing actually the application of molecular sciences and precision oncology for older patients to a far more extent than we saw earlier. And even in older patients, we are able to achieve better quality of lives and more effective treatment with this area of molecular precision oncology. Why I'm saying that is earlier, after a certain age when cancer was diagnosed in the 80s and beyond, uh, a treatment protocol was not really considered that seriously. And immediately the thought of more palliative care was being brought. So that I think has changed with more advanced oncological methods and drugs available, and of course guided by this molecular oncology. So I'm happy to share some of my thoughts around this. So I'll try to share my screen and please let me know if you are able to. Anybody can give me a heads up once you're able to
Yeah,
see
we can see your screen.
Thank you, sir. So, at MOC, we are a small private group, but trying to make meaningful impact in the treatment of cancer patients. And I've assimilated some interesting points which I thought is worthwhile sharing to really understand that relationship between aging and cancers. I'm sure these are very basic points and most of you all know. So it's just maybe a review talk, I can say. Is nothing exemplary here. But following maybe this talk, while we get into the panel, then a panel discussion, we'll look into more specific instances of old age cancers and how treatment interventions can be modulated, or what are the complexities and challenges thereof. So, starting by looking at the role of aging in cancers, again, as I said, classically, we know that cancer is a molecular genetic driven disease, and so is aging. The same factors which are leading to aging are also factors that promote cancer. As long as that aging process is not stalled or is not stopped. Um, and the molecular factors that we can talk of are like, somatic mutations accumulating in cancer cells. These are genetic alterations which are abnormal, changes in the gene which are abnormal, which keep on accumulating with age. And there comes a tipping point when those cells stop dying or undergoing senescence, but rather multiplying, and that is cancer. In a similar way, there is proteostatic imbalance. There is a very fine balance between formation of proteins and degradation of proteins. Certain proteins are promoters of accelerated cell multiplication. So those proteins are kept to that level where they allow physiological cell multiplication. And we can understand physiological cell multiplication in the bone marrow, which is constantly replicating, or the epithelial cells of our skin or of the gastrointestinal tract, which are constantly undergoing this multiplication. But once that proteostasis is imbalanced, that is when the growth factors accumulate and they cause abnormal cell multiplication. We'll talk a little bit at the end of this presentation on the mitochondrial factors, but the mitochondrial genome, which is separate from the nuclear genome, is also an important factor to allow cancer cells to sustain. Senescence is the aging factor, and we won't be going into too much details of senescence other than, it's a separate topic in itself, and I am not an expert. But then these senescent cells are accumulating certain molecular factors which ultimately promote cancer. Epigenetic dysregulation is an important area where the change is not happening within the gene, but is happening on the surface of the gene. What you see, the round thing here and a cylinder, the cylinder is the histone protein around which the DNA is coiled. And if a methyl group comes and sits, it can either activate a gene or it can inactivate a gene. This is called epigenetic dysregulation, which again can promote cancer-related genes. Immune dysregulation is a very, very important factor. So the last two or three that we see here, immune dysregulation, DNA damage, and telomere dysfunction, these are very important molecular changes associated with aging and cancer. And why I say so, because there are now drugs which can be used to reverse that mechanism. Like if you have an immune dysregulation and the immune system is not able to recognize cancer cells, now you have drugs which can uncover that and allow the immune system to go and combat the cancer cells. So that is called immunotherapy. Similarly, DNA damage, accumulation of cells with damaged DNA is a vital factor giving rise to certain cancers like the ovarian cancers, pancreatic cancers, prostatic cancers. And we have drugs which can stop this damaged DNA cells to accumulate. So again, another therapeutic importance. Similarly, now there are drugs in the pipeline which will not allow the end of chromosomes is called telomere. And if telomeres are damaged, these tend to join together with other chromosomes, activate certain genes. So this end of chromosomes is a very important region, and we are losing telomeres as an evolutionary factor. So telomere dysfunction is also associated with aging as well as with cancer. So these are the basic, I would say, um, uh, 8 mechanisms, and we'll talk about the octagon of molecular mechanisms in cancer, but this is an overview of how genetic abnormalities or molecular abnormalities are leading to cancer. Um, so some issues in progressing the slides, but so the areas that we are researching in molecular medicine related to aging and cancer can be divided into two domains. One is how aging is impacting cancer progression. This is very easy to say, but then can we modulate aging effects so that the cancer will not happen or will be delayed? So that's an aging intervention for managing cancers. The second part is when we treat aged patients, we see much different side effects and much different outcomes of treatment than we see in younger patients. Older patients are not able to tolerate chemotherapy. We know this general dictum. So how can we do something which will not induce this? And we also know that anti-cancer treatment is associated with several impacts which are actually similar to aging. And a cancer patient on chemotherapy loses hair, um, has a bad gastrointestinal side effects, loses the hematopoietic vigor. So there are many effects which are effects of anti-cancer drugs, but are also correlated with aging. Can we prevent this aging effect of cancer treatment? So these are the two burning areas that we are looking at as of now. Coming back to our octagon of what we spoke of aging and cancer, and just reiterating some of those factors from a therapeutic standpoint and as well as a research standpoint. So the A2H, that is the octagon here. What are age-related or age-specific therapies? Can we personalize cancer therapies for older patients? That is one area. The other is, are there any biological guided interventions which can actually help in the biological factors of both aging and cancer? Can we deal with those impacts which are related to both aging and cancer, like muscle loss, sarcopenias? Uh, how can we intercept the senescent cells so that cells which are supposed to die off and newer cells form, rather than the cells which are supposed to die persist and replicate? Can we have earlier diagnosis of cancers, especially in older patients, through artificial intelligence and minimally invasive tests, because it's difficult to investigate older patients with more invasive methods? What are the evidence-based therapies which can help to give easier treatment to cancer patients? How can we enhance quality of life of cancer patients? Developing geriatric oncology workforce, and I'm sure Dr. Prem, once his tech glitch is resolved, will talk more about it. But we definitely are in need of more people who are trained in geriatric oncology. So those are the factors that are important factors in aging and cancer. I hope my audio is working fine, because I'm not looking at any video feedback. I hope you're not losing my audio and are able to see the slides.
We can hear you.
Okay, sir, thank you. So when it comes to genetics, of course, there are hundreds of genes that are associated, but there are certain common age-related genes which are involved in, which are implicated in cancers. We all have heard of BRCA mutations. Now, commonly, we know that BRCA is a gene that is inherited. The gene defect is inherited from one generation to the other. But surprisingly, as we are investigating more and more aged cancer patients, we are seeing that somatic mutations in this BRCA gene, which is basically a tumor suppressor gene, just like the last one, or TP53, the somatic mutations in BRCA are happening, which are stopping the function of this tumor suppressor gene and hence leading to cancer. Same with this gene called CHEK2. FGFR is a growth factor related gene, which basically, once activated, leads to cancer. And there are other mechanisms like Notch1, PARP, SASP is something we'll talk about a little bit, which is senescence associated secretory phenotype, which is both associated with aging and cancer. So just to give you a heads up on some of the genes which are associated in this mechanism. A very commonly seen phenomena is CHIP, or clonal hematopoiesis of indeterminate preponderance. Now, what happens is that there are certain genetic changes which happen in the bone marrow, which are different from what happen in tissues. But sometimes we see that these mutations which happen in primitive bone marrow cells or blast cells within the marrow are acquired or continue persisting either in the peripheral blood or in the tissue organs. This type of mutation, which is classical of the hematopoietic cells, but are seen in areas which are non-hematopoietic, like in mature blood cells or in tissue cells, is known as clonal hematopoiesis of indeterminate preponderance or indeterminate potential. This is a factor which is often picked up by easy genetic tests and are also known to be supported by aging, by constitutive genetic changes in those organs, by lifestyle changes, infections, and toxin exposures. And this clonal hematopoiesis is a sort of a devil in disguise because we are often likely to miss it, and it leads to various degenerative conditions like atherosclerosis, aging, as well as to other malignancies, not just hematological malignancies. So just an overview that this is a factor. It's a lurking kind of a defect. Then, while we look at biological hallmarks of aging, they are associated or they are triggered by two different factors: intrinsic factors like the genetics of makeup of the tissues, the microbiota, and other diseases. And there are extrinsic factors like lifestyle, diet, and toxin exposures, which are everywhere. So those create the hallmarks of aging. And when it is triggered by disease-specific risk factors, it leads to all these chronic diseases related to aging, like neurodegenerative diseases like Alzheimer's, cardiovascular diseases, osteoporosis, muscle loss of aging, diabetes, and even cancer. And finally, this is the funnel which holds disability and death related to aging. So to know this, we know what is it that we need to target. Now, there are a lot of disparities that we see in older patients with cancer. The three trigon of those disparities are: one, which we can't do too much about, which is the patient. Patients receiving different types of medications, their history of medication is different, their mindset in addressing or in looking at cancer is different, their mobilities may be different. So all these are individualistic factors which affect the outcome. Then there are socio-demographic factors, like, in a city like Mumbai, there is all sorts of tertiary and quaternary care available. The gaps between the minority groups and genders are less. But when you go to villages and in other tier 2, tier 3 cities, these gaps become significant. Women with cancers are coming for intervention much later. There is an ICMR data which was also, I think, published by Tata TMH, is that when we look at tier 2, tier 3 cities and villages, the ratio of women who are presenting with more advanced cancers is much higher than men. So it's simple gender disparity. And finally, the health system, we can't complain more about it, that geriatric assessment, multidisciplinary workforce, and infrastructure are definitely deficient in public healthcare system, which add to the disparities of older patients with cancer. Now, I wouldn't go into too much detail. This is a busy slide, but then what it shows is that while on the one hand there are molecular factors, the other hand there are tissue microenvironment factors, factors within the cancer tissue or the tissue which becomes cancerous, which together come and cause this age-related change, where inflammation is a predisposing factor to cancer. And inflammation, often in medical or in pathology terms, is considered to be a noticeable inflammation. Like, you get a rash or you get a injury and that heals with inflammation. But then there is more subtle tissue related inflammation which is continuously going on. And when that goes to a certain tipping point, again, that inflammation can give rise to cancer when the body's immune system is no longer able to curtail that cell multiplication. And there are various different terminologies here, like antagonistic pleiotrophy, which basically is a imbalance between the balancing mechanism, how genetic changes happen. Then those genetic changes are supposed to be eliminated, but if they keep on accumulating, then they will give rise to a cancer cell. We've already spoken about clonal hematopoiesis. Driver mutations are something which are very strongly being looked at in various different cancers like lung cancers, breast cancers. Driver mechanisms are those which are driving a cancer. So if we know in certain cancers the driving mechanism, we are developing drugs to stop those driving mechanism and hence treat cancers like never before. So various different mechanisms. So just some simplistic images of showing you how clonal evolution of cells can be impacted by the microenvironment. Now, this cartoon shows that a normal cell may assimilate some genetic alterations and we call it mutant cells. In a normal physiological course, or where the microenvironment surrounding the tumor cells is, so as to say, able to curtail that, you eliminate those cells and you maintain the tissue function. This is called a tumor suppressive environment. But when you don't have that immune mechanism to destroy this mutated cell, it goes on multiplying, and that leads to perturbed tissue function and even to cancer. Just to show that this mechanism is not related only to cancers, but is associated, the same clonal evolution and inflammation is associated with all types of other degenerative diseases like atherosclerosis, lung fibrosis, that is becoming very common, especially in all these urban cities with more pollution. So it's the same mechanism. The opposite of that is, can we maintain a youthful organ system? This is the soma, means the tissue, the organic part of the body. Of course, the other sort of the synergistic part of soma is psyche. So, maybe another meeting, Dr. Prem will organize a discussion on psychic impacts or psychological impacts of aging, which is also an important factor. But in this talk, I talk only about the soma, that is the tissue part. So the factors which are related to maintaining the youthful soma is also important. We've already seen redundancy, that is, the aging cells need to be removed and the younger cells need to be maintained. You need to have mechanisms of maintaining the DNA repair mechanism so that damaged DNA is not accumulating. You need to have intrinsic quality control in the microenvironment of the tumor, of the organ, which includes immune surveillance, that the immune system is constantly looking for those damaged cells which are being removed from the system. So that's how the youthful soma needs to be maintained. And when any of this is damaged, that will lead to age-related cancers to happen. And when we contrast that, that is what is shown here, that while in the youthful soma, you have the robust functions that maintains tissue health and eliminates the malfunctional clones. This maintains the youthful soma as well as individual fitness. But when all these mechanisms are not functioning, that is when you have aging. Of course, you trigger that even more with factors like smoking, obesity. Now we very well know that it has been scientifically explained and shown that obesity triggers both aging and cancer, and smoking and tobacco exposure, alcohol, is very well established. We all know that the Surgeon General in the new US government has also shown that all levels of alcohol intake is carcinogenic. So the feed-forward loop of aging and clonal evolution is the cycle which we need to break for preventing age-related cancers. And that is where we are seeing that mutations and the immune system, inflammation, adaptive landscape are all accumulating to lead to that clonal evolution, which is leading to cancers. Another burning topic in today's times, and actually, a Nobel Prize in medicine went to this a couple of years back to scientists who showed that how autophagy is an important mechanism related to cancers. So, with increasing age, there is a decrease in the autophagic flux, and the cells which needs to be eaten up by the process of autophagy. Autophagy means when you eat your body's own cells, which is triggered by even simple lifestyle factors like fasting and intermittent fasting, which is sort of a very overhyped thing now, does have an important role in preventing senescence. So autophagy is an important factor, and now there are actually very simple molecules that we have discovered, like hydroxychloroquine, which is used for treatment of malaria, which is an autophagy balancer and can help in the treatment of cancer patients, especially very aggressive cancers like colon cancers with KRAS mutations. We have seen that autophagy enhancers like hydroxychloroquine, if added to the cancer treatment, can enhance the outcome of cancers. So just that factor that if you reduce autophagy, then you will lead to cancer progression. Mitochondrial DNA mutations, which I slightly spoke of in the early slides. So again, mutate the genome in the cell is in the nucleus and in the mitochondria. Mitochondrial genome is often unique from the nuclear genome, and we have seen that mitochondrial genome undergoes more rapid aging than the nuclear genome, because mitochondria is the powerhouse of the cell. That is where all the metabolism is happening. And this oxidative phosphorylation, which is happening in the mitochondria, is actually assimilating more defects in the mitochondrial genome. And once it reaches a tipping point, that is where this mitochondrial mutations or genomic alteration just opens the floodgates to cancers. So finally, this is just to give you some of those names of molecular alterations which are associated with both aging and cancer, and where we are having many therapeutic interventions. So I'll just start from the top block, which is that, as the reactive free radicals are accumulating in the cells, we see activation of certain pathways and certain genes like ROS, which are associated with activation of other downstream pathways like PI3 kinase, AKT, mTOR. Very important, because now there are drugs for all of these molecular targets which can block these genes and hence prevent the progression of cancers. Similarly, DNA damage, ERK, JNK are all other molecules where we have upregulation of these causes cancers, but we have drugs to prevent these or block these. mTOR is a very significant pathway, again, associated with nuclear sensing, and we can block that with drugs. Similarly, increased anaerobic glycolysis and lactate accumulation is one of the factors which is very well established, which leads to sarcopenias, age-related muscle loss, as well as to aging. So we don't want actually increased anabolism happening in the presence of this, which will promote the cancer cells. And we don't want reduction oxidation imbalance. When this happens, we want these cells to die. If these cells don't die, then they will form cancer cells. Unlike just the opposite of what happens in young age, we want more anabolism because we want the body tissues to grow. Cellular senescence is very strongly associated with tumor microenvironment. Again, some of these genes which are giving rise to cellular senescence and are preserved in cancer or upregulated in cancer, like the cyclin-dependent kinase pathway, are very important because now we have developed drugs like CDK4/6 inhibitors. Palbociclib is one drug which has now become standard of care for hormone positive breast cancers, because we know that breast cancer cells which are hormone positive actually have hyperactivated cyclin dependent kinases, and if we can block that, then even metastatic advanced breast cancers can be controlled. I mentioned earlier in my presentation that senescence-associated secretory phenotype is a molecular mechanism which is associated with both aging and cancer. This basically is accumulation of all these molecules within aging tissues, which physiologically help in the damage of the cells, but if they keep on assimilating, then these senescent cells turn into cancer cells. So wouldn't go into too much details there. DNA damage mechanism is also an aging mechanism as well as a cancer mechanism. Why I kept this slide is now we have a fantastic category of oral drug called PARP inhibitors, which can actually allow the cells which are accumulating DNA, damaged DNA to accumulate, and then make the immune system kill those. So just a tablet which can oral drug which can counter this very complex mechanism, which earlier was untreatable, because how do you prevent the cells which are accumulating damaged DNA? So now there is an oral drug called PARP inhibitor which can just make the DNA damaged cells to accumulate to that extent that they are destroyed by the immune mechanism. Again, a drug which is commonly being used even in first line treatment of ovarian cancers, and now in prostatic and pancreatic cancers as well. Last, telomeric shortening. It's associated with aging as well as with cancers. This is a burning topic which a lot of researchers all over the world are looking at, how we can basically inhibit this enzyme, the TERT mechanism, which leads to damaged endpoints of chromosomes to assimilate. So wouldn't go into too much details of that. I think I'll stop there. And sorry if I have crossed my time limit, but yeah, happy to answer any questions.
That's wonderful. Thank you very much, Chirantan. I would first like to ask if Prem is now sorted out this technical glitch and can take over. Prem, can you hear me and can you speak?
Yes, I can hear
Okay.
you.
Okay. Okay, so over to you now. For the rest of the program, I will hand it over to you. Thank you.
Yeah, so thank you, Dr. Bose, for the presentation. Uh, yeah, as I discussed, the technical glitches become difficult. So would you want to obviously share those cases, and then I can get people into discussion?
Yeah, sure. Shall I run the slide deck for the cases? And how much more time do we
Yeah, sure.
have? I think I've overshot with some time, is it?
It's okay. I mean, we try to finish by 8, so maybe we can take a bit of lesser cases, but that's okay.
Yeah, sure.
So
Okay.
in the meanwhile, as you share, I'll just welcome the other panelists, Murli. Thanks for being here, Dr. Gina and Dr. Maria. Dr. Maria is joining us from Spain, and Dr. Gina, of course, from Kochi, and Dr. Aditya from Bangalore.
Happy to be here. Thank you for having me.
Hi, everyone. Is again the cases slide deck visible?
No, sir.
Oh,
We can see you, but we can't see your slides.
okay, sir. One second. Now?
Yes, now we can see. You can make it full screen. Yeah, perfect.
Yeah, I just assimilated some of our real life cases of, close to 80 years plus PS 2, 3 patients. So, just bringing this out to see the opinion. And of course, these are my slide deck is focused on the molecular findings, but we can talk about other factors associated when looking at this kind of cases. So, Purvish sir, can we start?
Yeah, please.
Thank you.
So can you?
Yeah, so basically, this is a classical case which we see these days more often, that when we have dual primary, we have two organs, individual cancers. Again, there can be some molecular mechanisms which are common, but at the same time, there are some molecular mechanisms which are unique. So this was a 79-year-old male with dual cancer in the lung as well as in the sigmoid colon. And the genomics were done for both the biopsies, the lung biopsy as well as the colon biopsy. And as you can see that we see KRAS gene mutation in both areas and exactly the same variant frequencies. So as to say that this may be not a common feature that we see, that the KRAS is driving at the same time both of these tumors. On the colon side, we see some of the classical colorectal cancer genes like dual mutations in APC, TP53, and this PIK3CA E542 mutation, which is predominant. On the lung side, we see mutation in ERCC, SMO, NF1. The lung tumor, which are usually KRAS mutated, do have this immunotherapy overexpression of PDL1, but both the tumors are microsatellite stable. So just opening this up to maybe geriatrician non-oncologists here first, what do you think? What is your approach when you find, first of all, what is your experience? Are you seeing older patients with multiple primary malignancies? And what are your thoughts when you look at older patients with multiple primary?
Yeah. So we can say,
Hello, can you hear me?
Dr.
Hello.
Prem, you're breaking off, but I think we can hear.
Hello, this is Dr. Gino
Yeah,
here.
go ahead,
Can you hear
Gino.
me?
Gino, we can hear you.
Hi,
Yeah, Gino,
I'm a
go ahead.
geriatrician from Cochin. I would be happy to take that question. In terms of VC, yes, multiple primaries, I mean, like dual primaries, we see that. But at the end of the day, I think as a geriatrician, when I leave a lot of decision to my oncologist, what the oncologist usually asks me is, to get a functional status evaluation to begin with, to have a list of the pre-existing other comorbidities, what are the other issues, how far do you see the patient will go on with or without the disease, and what do you think is the best decision at this point for the patient in terms of even stepping up with attempting to treat any one of those. So usually we have a multidisciplinary team meeting where our entire team sits together. Apart from the tumor board, prior to the tumor board, they actually have this MDT meetings with the geriatrics team, where they actually kind of run through the entire case and tell us the scenarios, tell us how long they would want to treat, what is the kind of treatment they would like to offer. And they always rely us on doing our comprehensive geriatric assessment, where we find the other headings, the other functional and cognitive and other headings of the elderly, whether that is suitable to take forth for a treatment or not. So that's given a lot of priority in our experience and in our center.
Right.
Yeah, Dr. Maria.
In Spain, we do the same. We have also a tumor board where all the doctors can comment the patient. They the pathologists commend this NGS genomic study, but the oncologist needs our comprehensive geriatric assessment to see how frail is the patient and how can they can resist or they can accept or tolerate the medications they want to give. So we also do these tumor boards to decide altogether which is the best option for the patient.
Yeah, thank you,
Right.
Dr. Maria. Yeah, Dr. Bose, of course, if you can involve us with.
Yeah, yeah. No, I think that is the challenge that, we cannot look at, we have to look at tolerance and the adverse effect profile of the treatment regime that we are planning. Because when we treat older patients, as I mentioned, with PS not so conducive to give aggressive treatments, that is where these considerations become very critical. And especially, we have families, actually, Dr. Prem can talk about that, who desist or resist from chemotherapies. They say that maybe we would like to have oral medications, we would not like to have aggressive chemotherapies. As it is, dual primaries become a challenge. So rather than the findings of this, my reason for bringing out this case was that dual primary malignancies in older patients is a double whammy. It's really a difficult to manage thing. And again, just to show you here how significant molecular mechanisms are, because the same KRAS mutation, which is definitely not a germline mutation, is happening in the same frequency in both the lung and the colon cancer. So sometimes it just, stares right at our face that this molecular mechanism is what has given rise to this cancer. So Avastin, bevacizumab combined with chemotherapy has been found to significantly benefit the progression-free survival as well as overall survival in KRAS G12V mutated cancers, which has been well published. So that's one of the personalization with whatever chemotherapy we are able to give to this patient. If we can add Avastin, again, looking at whether there is coexistent comorbidities like hypertension or cardiovascular diseases. The other thing is the RAS impact of MEK inhibitor category of drugs like trametinib. So that is another oral medication which, although has got a significant skin toxicity, but maybe, just a bypass in case that we are unable to give the chemo to the full course. So medical oncologists on board, what do you think
So,
of this case?
So, Dr. Bose, thanks for involving me. I think the first two questions are very relevant, which is does the patient want the treatment, and two, will the patient tolerate the treatment? And a medical oncologist role will come only after a comprehensive geriatric assessment of these two questions are done. Having assumed that answer to both of them are yes, in this scenario, uh, some sort of chemotherapy is necessary. So assuming that the age is just a number and the patient is reasonably fit gentleman and does want, or a lady and does want treatment, in that case some form of chemotherapy for sure, because a non chemotherapy modality simply is not going to work, given the number of mutations which we are seeing over here. It's just trying to give some be some bevacizumab or some kind of target therapy here would not be enough. Number one. Number two, I think um, the other question is which is the more dominant or the more aggressive of the malignancies. We can have either the lung being aggressive or the colon being aggressive. Now we know that if it's a lung and a colon, almost always lung is the most aggressive one. Lung is going to get the patient within a few months, and colon will still, we can pull on for a while. And here we have got one positive thing in terms of the high PDL1 score. So a chemo which is probably a little bit more tailor made for lung with an immunotherapy option is what I would do. Particularly in this case, if I see this tomorrow morning in the clinic, and if the patient really warrants and wants treatment, I would choose a chemo immuno combination here.
Just to quickly ask Dr. Bose and Dr. Aditya, that is cost usually a deterrent for doing NGS at all, or when we actually explain and people are more than welcome to do it, or is it something which is still a challenge?
So
I
the
mean,
answer actually depends on, unfortunately, which setting we practice in. If it's a large government or a NGO funded facility, then cost is very much a deterrent. Fortunately, where I practice in, it's a tertiary quaternary care corporate hospital, which means almost always, given that we have got our own versions, the Indian versions of NGS, which are not too expensive. Almost always, in a case like this, we do explain to the patient, and patients do end up undergoing an NGS.
So, Dr. Prem, actually, yeah, reiterating that point, this, as you can see, the patient undertook we advised for a target hotspot NGS panel. For each specimen, this test costs about 20 to 25,000 rupees. So, unlike those times few years back where we were really looking at uh, tests costing more than 1 lakh rupees being sent to overseas labs, now we have very good NGS labs locally here. And I think, the totally concurring with the medical oncologist, it gives a light to the treatment. Again, in this particular case, because of the PS of the patient, a single drug chemotherapy with an immunotherapy and Avastin has been started. It's just about 2 months, but I think the patient is tolerating the treatment well.
okay, great. So, Dr. Bose, maybe we can take another case and then we'll call it.
Okay, sure. A slightly different scenario. Again, it brings out a few different agendas which I thought are important to discuss, and especially, the moment liquid biopsy is another term which is very, it's like hotcake in the market right now. But this is the case, again, a colon cancer, um, uh, where it was a poorly differentiated metastatic disease. The patient had underwent colectomy in 2021, and then there was a recurrence. When genetic testing was done, it actually had multiple different things. It had a CHEK2 mutation, a germline CHEK2 mutation. As I mentioned, this again is like the BRCA gene. It's a tumor suppressor gene, and it's associated with various familial cancers. But at the same time, it also was Lynch positive. It was microsatellite unstable, or MMR deficient, with loss of MLH1 and PMS2. And then the NGS also revealed a BRAF mutation, which is again a well-known driver of colon cancers. What we did post first-line therapy in this patient is liquid biopsy. So I just, in the interest of time, bringing to the main questions in this case, liquid biopsy is a blood-based method to evaluate the tumor elements which are coming in the bloodstream, mainly circulating tumor DNA and circulating tumor cells. Uh, Sometimes this helps in initial evaluation of patients, but we are finding it more effective. And now ASCO has given in its guidelines of colon cancer management that liquid biopsy assessment can be used for MRD assessment, for deciding adjuvant treatment in operated patients. And that's what we did. And if you see the graph on the right side, don't go at the therapeutic implications, but the graph shows that after treatment, the both CTC and ctDNA concentration, CTC was nil from the very beginning, 2 times assessment. ctDNA dropped to nil. So just opening up this to the forum, maybe the medical oncologist first. Do you use liquid biopsy for your cancer patients? And what are your thoughts on, the general application of liquid biopsy?
So at least I definitely used liquid biopsy in day-to-day clinical practice, especially in subsets like lung cancer, colon cancer, and hepatobiliary cancer. These are the three common subsets where I use liquid biopsies. Number one. Number two, obviously at diagnosis, I would prefer a tissue biopsy and a tissue sequencing for advanced malignancies. But at progression, liquid biopsy is a tool which we must embrace. We must let go of our fear, and which many a times is born out of ignorance about this. Because see, to be fair and honest, when I was training, I had no idea what a liquid biopsy meant. This is all so recent, so we are all learning about liquid biopsies on the go. But at progression, liquid biopsies are extremely sensitive in picking up both on target and off target mutations, especially if there are some driver mutations and the patient has been on a tyrosine kinase inhibitor. Number one. Number two, uh, liquid biopsies uh, are getting the technology is getting better with each day. And at progression, though, we must look at it in all of these settings.
Okay, so yeah, thanks, Dr. Aditya. Let me just get in Dr. Maria and Dr. Gino. So I think we have always, as geriatricians, we try to be proactive in the sense that we want to give the best possible care for older adults, in this case, of course, with cancer. So in your experience, Dr. Maria first and Dr. Gino, where do you think precision medicine has actually given us that extra impetus? No, that we might not achieve cure, which is there to quite a bit of time in our case in what lot of patients, but the best possible care. So where do you think technology and precision medicine has actually helped us in giving them a better quality of care? Dr. Maria first and Dr. Gino then.
I think it's very useful to have this precision diagnosis, because you can give the patient a better treatment and more specific treatment. But I think that with these old patients, it's obvious that comprehensive geriatric assessment helps to the oncologists to select or choose the better treatment for our patient. Obviously, we have to ask the patient and the family which treatment do they prefer. But if we have a well comprehensive geriatric assessment done, and we know how frail is the patient, the oncologist can choose better the treatment that they want to do. Obviously, asking the patient if they want to start with this type of treatment. But I think is nowadays is very useful to have this precision diagnosis, this NGS, but also our comprehensive geriatric assessment can help to these patients to be well treated and to have better quality of life with the tolerance of the treatment and so on.
No, thank you, Dr. Yeah, Dr. Gino.
I think precision medicine is the heart of geriatric medicine, and precision medicine makes geriatrics different from the regular medical practice. So while incorporating or talking about precision medicine in geriatric oncology, in terms of the molecular oncology and other stuff, the precision medicine, even without bringing in the molecular and very, very hardcore stuff, where we try and see what is really important in the patient's life, whether managing the cancer is the most important thing, or whether addressing the heart failure, which is not helping him maybe do his daily activities. What is more important? What drug is more relevant? What intervention is more suitable at this point? And that decision changes from day to day. Probably what is relevant today for the patient might not be what is relevant for him tomorrow. And that time to time decision which is taken in the best interest of patient is what makes geriatrics and geriatric oncology particularly challenging. When we sit together around the table and we discuss the cases, when the modalities keep changing, when the treatment options keep changing, what is really important for the patient's better living is what is detrimental in precising and localizing to a treatment protocol for the patient in terms of not just cancer, for all the comorbidities. Yes, developing algorithms based on automatic predictive models using AI is something which we have been closely experimenting on, especially in the oncology setting where we're not able to do CGF for everyone. We've just recently incorporated automatic something similar to a Google form where the document is being recorded online and is being sorted out so that only the particular relevant area needs to be addressed by the geriatrician once the social worker takes care of the basic CGA. So, much more things can happen. This is a very rude and very crude method, which we are not rude, crude method, which we have been using. But I think more technology and more monitoring devices will help us in addressing the personalized needs of the patient, whereby the precision medicine and the personalized medicine will come into a better geriatric oncology practice.
Absolutely. I think Dr. Maria and Dr. Gino, you hit the nail on the head. Dr. Bose, actually, thanks a lot for doing this. I mean, the basic highlight for today was to actually make people understand that precision medicine and precision oncology is not the same anymore. It's actually such a relevant thing to, I mean, medicine itself. So it is something which should be taken up more even aggressively and according to the best possible chance should be given for our older adults to have a choice to get that treatment rather than us only thinking about maybe the cost factor or maybe that what we can achieve by this, because I'm sure that you in your practice get a lot of questions that why is it even needed to do, we have done everything possible, we have done all the investigations. But I think this is a good beginning and for people to understand. And I mean, you cannot include precision oncology in a half an hour session. That is definitely there. But thanks a lot, Dr. Chirantan, for highlighting the basics. And thanks a lot for people for joining the panel. Listen, I have to apologize for my technical difficulties today, but you never know when technology fails. That is a disclaimer. So thank you. Thanks a lot for everybody who's been on this panel. We can close now. Thank you. Yeah.